So to start with sort of performance measurement, let me just reflect on the title that came out, even though I let mental health and its impact on me, care and outcomes. We have to, what it should say is mental health and its impact on medical care and outcomes, which is kind of, just be careful. To start with, I just want to invite my friend Sanjeev Sokalingam up just for a little public service announcement. No, he and I, come on up. He and I are not working jointly as concierges at the hospital. We have the same suit on, but I want you to take advantage. Harry Rosen's a fine menswear suit. Hashtag 2 for 1. Hashtag MPA 2015. It's a great store, great service, great suit. Okay. What I wanted to do, I'm not going to talk much about performance evaluation because I've done too much talking about that, and because this is an education talk, what I have decided to do was to talk first about just the notion of complexity, and then give you a little bit of an insight into what's happening in Ontario, a province, for those of you outside of Ontario, a province of 13.5 million people, and some of the outcomes that we're able to measure with the data that are captured because of our one payer provider healthcare system. Okay. Just routine disclosures. I have funding from the Ministry of Health and Long-Term Care here in Ontario and some other foundations, but no conflicts to disclose as it relates to this talk. So I think the Medical Psychiatry Alliance could just as easily have been called the Complexity Alliance. And, I think there has been more and more discussion about complexity. And I think what the major themes are that for the longest time we have been dictated by guidelines which have been fed in by either expert consensus mostly or randomized controlled trials. All this evidence and consensus is based on one disease profile, one treatment, one outcome. And that hardly reflects the reality of a day-to-day practice. So I think there's just a growing consensus that the way we have thought about incorporating evidence into our practice is flawed and ultimately isn't generalizable to what comes in through the door day after day. There have been in Ontario a couple of new initiatives to address complexity. I think it's way too early to determine whether they've had an effect, but HealthLinks is something that our Ministry of Health has funded that tries to reorganize care providers to more effectively provide care. It would be somewhat similar for the U.S. colleagues to the Medicaid medical home. It's a little bit like that. And then, of course, there have been different efforts to implement shared or integrated care in Ontario. Although, for me, that seems kind of as somebody who's interested in sort of evaluation, the shared care models have been a bit plagued by definition issues. I think it's hard for people to define clearly what shared care means, and accordingly, it's been, I think, a little bit harder to determine whether shared care has been a success. I don't know. This is just something that I'm reading currently, and I think it's something worth reading for people who are involved in complexity. And it's a cardiologist, U.S. cardiologist named Eric Topol. He wrote previously, I think, The Creative Destruction of Medical Care, and this is a recent book he has, The Patient Will See You Now. And it's based on two premises. One premise that's really important for the Medical Psychiatry Alliance, which is that moving forward, we should be thinking about how to meet the needs of the patient rather than patient meeting the needs of us. And I think I work at the Center for Addiction and Mental Health, and we're trying our best to undo a lot of decisions that really met the needs of organization and not the needs of the people who we serve. And to give you a concrete example, we just underwent a process where we figured out that there were about 85 different clinics, each of which had their own intake. So if you're a primary care provider or a patient, how on earth do you wrap your head around 85 different services and decide which one to send to? And so one solution was to create what we called Access CAMH. One door, and then we figure out after the door, but one door for people, to either primary care providers or people to self-refer. And that's just one example. The other aspect of Eric Topol's book is about the emergence of new technology and how we integrate it, and I think that's also a really interesting thing to think about as we move forward in the Medical Psychiatry Alliance, because in many ways every other facet, including our patients, are way ahead of us in terms of the use of technology, and we haven't even if we look at the implementation of EMRs, we're kind of slow off the mark in terms of using technology. So what is the impact? Well, there are many studies, and in fact, there's just a new study published online October 28th in JAMA Psychiatry, showing that if you have a severe mental illness, you have a 15 to 20 year reduced lifespan. In fact, the study that was just published said that it was climbing. It was closer to 30 years. And in this new study, which 1.1 million people, 74,000 deaths, showed that if you have schizophrenia, your standardized mortality ratio for cardiovascular illnesses is 3.5 times that of somebody without schizophrenia. COPD-related deaths, 10 times the death rate of people without schizophrenia. And in terms of if the proportion of the deaths observed in schizophrenia, the biggest killer was cardiovascular. 35% of all deaths were due to cardiovascular deaths. So, and there is emerging evidence in parallel that's suggesting that the second generation or atypical antipsychotics are, if anything, accelerating the gap in mortality. So this is something, to me, people with severe mental illnesses, with the complexity of the comorbidities that they carry, is really the canary in the coal mine of a healthcare system. If we can do right by these individuals in terms of provision of care, probably we can generalize that to just about anybody. My graduate work was looking at the relationship between depression and cardiovascular illnesses on outcomes such as mortality, and I found this very interesting. That in 2014, a bunch of cardiologists got together, and they didn't. There have been tons of studies, including lots of meta-analyses. You can see there are 4 meta-analyses now looking at the issue of whether depression is associated with mortality. That's no longer at issue. The focus of this systematic review was to answer the question, should depression be elevated to the status of a risk factor like blood pressure, like lipids, and I think that's a really, really interesting question. And their conclusion was yes. They said that there was abundant evidence that depression was a risk factor. And that got me thinking, the risk factors that we think about, not all risk factors are reversible. So family history is obviously a risk factor that you can't do anything about, but a lot of them are. And so the question is depression a reversible or irreversible risk factor? And I don't think we know that yet. And certainly, there's only been, despite 44, but 70 or so studies looking at the relationship between depression and mortality, there's been only one randomized controlled trial trying to determine whether treating depression actually changes cardiovascular outcomes. The answer is no. But then I think there's the question of how it could be acting as a risk factor is interesting. And much of this long 70-plus study industry looking at depression and cardiovascular illness outcomes has to do with sort of biological mechanisms. So neuroendocrine dysfunction, this heart rate variability and the autonomic disturbance. You know, when you put a depressed person's platelets in a test tube, they stick together more than somebody without depression. And when you sprinkle in some Prozac, they can tend to get less sticky. None of this has been translated into sort of trial level evidence, but there's all sorts of biological mechanisms. But again, I think that is kind of much more work needs to be done. But for me, that's interesting, and I think that's an avenue of worthy pursuit. But what do we know about depression and people who have depression, and what do we know about how we manage cardiovascular illnesses now? Anytime you look at a depression population, what you see is an incredible loading of all the risk factors we know already exist. So people with depression are more likely to be obese, more likely to smoke, more likely to adhere to lifestyles that are not friendly to cardiovascular health. And then once somebody has a cardiac event, there's all sorts of evidence to show that if you have depression, you're way less likely to adhere to secondary prevention methods like attending rehab, being motivated to follow through rehab. And I think the way our Medical Psychiatry Alliance is focused is much more on how do we deal with the last two? How do we promote wellness in people with complexities of medical and psychiatric comorbidity? And how do we better provide care and in such a way that it leads to success in the way, according to the evidence that currently exists? There is much less of an emphasis in our, I think it's safe to say, in our Medical Psychiatry Alliance about pursuing the biological mechanistic pathways related to the associations. So I'm going to show you now a little bit of sort of the big picture of what we have access to sort of set the stage of what we're dealing with in Ontario to provide a foundation for what Sanji's talking about next in terms of different models of care and the further discussion, which is how do we train people to manage to do what Eric Topol is advocating, which is to serve the patient's needs. And whether we're talking about education or how we provide care, I think the one major theme for our Medical Psychiatry Alliance is we can't continue doing the same thing and expect success. That the Medical Psychiatry Alliance is really about a radical departure from what our status quo, whether it's education, whether it's provision of care. We must try to do things differently in systematic ways. And equally importantly, and that's kind of my role as Director of Health Outcomes, we must evaluate whether these radical departures work or not. Otherwise, we will contribute to what in Canada is a fairly large collection of non-evaluated pilot studies that go nowhere. Okay, so this is work in Ontario. My mental health group has developed ways to identify every single one of the 130,000 individuals who has a diagnosis of schizophrenia in Ontario. And with this study, what we did was we took people with schizophrenia versus those without and determined their outcomes at their first heart attack or myocardial infarction. And we did that because MI care is pretty standardized, so that when you present with your first heart attack, theoretically you should get exactly what you need based on pretty well worked out algorithms. And what we found at the bottom was if you have schizophrenia, you are 50% more likely to die within 3 months of discharge. And when we look at population-based, outcomes, we're floored when we see a 20% gradient. So a 50% gradient is just a crazy difference in death likelihood in such a short period of time after your first heart attack. Then we looked at what kind of care they're getting, and so this is within a month of discharge. if you had schizophrenia, the exact opposite happened. You were 50% less likely to get catheterization or bypass surgery, and 50% less likely to see a specialist. And I was helped. I initially submitted this for publication, and one of the reviewers, one of the anonymous reviewers, took issue with our procedure and specialist findings, the care part, and said, yeah, but these individuals, they just don't show up. So how can you say that this is a quality issue when people don't show up? I had a personal reaction to that, but it allowed me and my personal reaction is you don't blame the patient for the flaws of a system. That's my personal reaction. But it allowed me to go back to the data, and specifically around the procedures, and we found out that 96 or 97% of the procedures, whether they're bypass surgery or catheterization, occurred during that first hospitalization. In other words, people didn't have an opportunity to leave. And we were able to show, the paper was better because we were able to show definitively, this is not a loss to follow-up issue. This is clearly a not being offered issue. And so what does that mean? And, there's no, stigma is the easy answer, but it's something we really, this to me, the mortality outcome is bad, but the procedure issue has to be a focus of the MPA. We have to figure this out. Right now, this is not published. This is stuff we're just doing. And again, it takes advantage of within Ontario. We know everybody who has schizophrenia because of our work. And we also know everybody who has diabetes. So the prevalence of schizophrenia in Ontario is about 0.6 or 0.7%. We now know that 19% of people with schizophrenia have diabetes. So about 1 in 5, which is a very, very high rate compared to the general public. We also know that even though schizophrenia accounts for about 0.5% of the population, it accounts for 2% of so you're four times representative in the diabetes population. So people with schizophrenia are dramatically overrepresented in the relative to their prevalence in the diabetes population. And what do they look like in comparison to people without schizophrenia? Well, they're younger. They are more likely to be male, and and the income relates to the fact that we link to census data and figure out the neighborhood income. They are way more likely to live in low income neighborhoods. So they carry with them all the social disadvantages that one would expect, which also has to be taken into consideration for MPA initiatives. I thought this was really interesting. So I've just shown you that they're about 5 years younger on average, but their duration of diabetes is the same. All this is to say that their age of onset for diabetes is about 5 years earlier than people without diabetes. And that doesn't sound like a lot, but when we think about how they manage diabetes, that is a profoundly long period of exposure to the ravages of diabetes. And if we think back to what we talked about earlier, this is what we need to intervene on to address that 20 to 30 year mortality gap. Moving forward from the other piece is that it's average of 9 primary care physician visits versus 7. These people are not invisible to the system. They're engaging with healthcare providers quite frequently. So what can we say about their care? And this is a little bit complicated, but this builds on work by my colleague Rick Glazier at I hate saying it, ISIS. That's my research institute, and we're going to rebrand it ISIS : we were ISIS first. I'm not sure that's going to take. But it stands for Institute for Clinical Evaluative Sciences. We're thinking about changing the ICs. I don't know. We're working on it. But we have Rick has operationalized guideline concordant diabetes care within our data. So we look at hemoglobin A1C, and we can measure how many hemoglobin A1C tests have occurred in a 2-year period, how many lipid tests have occurred in a 2-year period, and having at least one eye exam in a 2-year period, all of which are defined in our Canadian diabetes guidelines, which look identical virtually to the US guidelines. And then all 3 of these things should be happening for good care. So what the 1, 2, 3 represent is looking at the odds ratio for having schizophrenia relative to not having schizophrenia amongst a diabetes population in terms of getting one of those 3, 2 of those 3, or 3 of those 3. And what you see is you start to see a discrepancy and impact of schizophrenia in quality when there's only one of those 3 done. So there's a 10% reduced likelihood of getting one of those 3. There's a 20% reduction in getting 2 of those 3. But the optimal care, getting everything that you should be getting according to guidelines, you're below 30% difference. So the quality of care, despite the fact that they're coming into contact with primary care more frequently, is way worse. This has to be a priority of the MPA. It's not contact; it's quality, and this is consistent with studies out of the U.S. We are just, these are unadjusted, but we've captured diabetes-specific emerge visits and diabetes-specific hospitalizations. And you can see that even though they're relatively low rate, they're not that low, like 8 versus 6% of the population, but you see similar, 20% differences that are conferred just by virtue of having schizophrenia. So people with schizophrenia, they have a burden of diabetes illness that's longer. It's a condition that's easily recognizable. We have standards of care that we're falling far short as it relates to people with schizophrenia, and we're starting to see the costly outcomes. And we are also I haven't shown this data, but what we're doing is we're doing a costing exercise for people with schizophrenia, not related to diabetes, just costs in general, and we're taking the costs of everybody who's alive in 2013, and what we're finding is a huge spike in psychiatric costs at the age of first onset, like 18 to 25, and then the costs sort of attenuate. But around 45 to 50, you start seeing this rise in medical costs. And so we're in parallel to this kind of quality work, we're also doing the policy relevant cost work, which is showing that, there are huge medical care costs that are probably preventable. And avoidable, because they're all hospitalizations, that are occurring. So this is kind of setting the stage. We don't know, and this is probably my last slide. We have, and there's this term I read recently, circular epidemiology. We have tons of epidemiologic data on how bad things are. We have no evidence about what works. I don't think we have even come close to figuring out how to deal with the kind of complexity that I've showed you, and the lousy outcomes that result. And despite the fact that complexity kind of is the norm, complexity is common, and so I am not an educator. I'm kind of a big data guy, but what I wanted to do was kind of set the stage for what is actually happening in our system, which is probably what's happening in the US and in the UK and everywhere. And the challenge is, for today, how do we radically do things differently to train people so that patients don't have to figure out how to get their complex needs met by going to multiple different providers and different sources. How do we integrate? How do we collaborate? And how do we measure success in training future clinicians? And with that, I will leave. Thanks.